Good morning. This is Francisco Jose Caicedo, American board orthopedic surgeon, trained in Universidad del Valle, Cali, Colombia, and also in the University of Alabama, Birmingham, with a fellowship in foot and ankle in the American Sports Medicine Institute under Dr. John Gould and Kigner direction. Today, this is part one of the English version of one of the most common pathology that we have in ankle and foot is the instability. And I want to share two concepts that are really things important. One is considering the lateral ankle sprain, like not only ligament damage, is a complex where I consider the three structures and three layers. One is the ATF, the anterior tibiofibular ligament. The second one is the CF, calcaneofibular ligament. I remember the calcaneofibular ligament is a ligament who support two joints, the ankle and the subtalar joint. And in between, there is not air. We have structures. One is the extensor retinaculum, the capsule, the peroneus tendon, and also the tendon sheath of the peroneus, that very strong and very good structure to help us to repair. So we're going to start with the concept first, and then we can go to the detail for surgery. So we know that this is one of the most common problems in sports injuries. 40% of the all sport injury is the ankle ligament injury. And we in the United States, we have 30,000 ankle sprain daily. And all of those, 34% become a recurrence. That's meaning in 3 months, the patient or the sports person has another episode of recurrence of this ligament injury. And unfortunately, 20% become chronic. And what's the problem with the chronic? The high incidence of post-traumatic arthritis. We have that 80%, 78% ended up with post-traumatic arthritis. So there is, in the physiopathology, there is two very important concepts that we have to consider. One is the instability, the functional, and the other one, the mechanical. What is the functional? The functional is the peroneus latency. So remember, when the ankle start turning in inversion, you have proprioceptors around all the structures in the lateral aspect of the ankle who send information to the brain, and the peroneus become a very strong stabilizer quicker. And the second one is the mechanical instability, and that's for the structure that we're talking about, that I consider as like a lateral complex. It's not only the CF, like a one post in anterior aspect, and the ATFLs in the and the ATFL in the anterior post, CF in the posterior post, and in between we have the capsule, and then we have the extensor retinaculum structures. So what is the long term for the surgery? What we try to prevent is the translation that happen when there's rupture of this ligament. So with surgery, we try to prevent or correct the anterior translation, internal rotation of the talus. That if it's going untreated, it will become a post-traumatic arthritis. And talking about patients, what's the reason they come to see us? So there's three mainly. One is the instability. The second one, the edema, and that's related with the P factors, the TFNs, and the interleukin, and all these products consequence to the inflammatory reaction. Plus, if we consider that the peroneus tendons can have a tear, and they create also tenosynovitis, all these produce a lot of signs and symptoms. Regardless of cost, we notice that it's about $3 billion a year spent in this problem in the United States. Excuse me. So, in talking about what kind of surgical techniques do we have available that is being recognized around the world? So definitely we know the anatomic repair is the gold standard. And we start seeing the Boston Lennard in back to 1966. They show us in his article hook incision and the repair of the ATFL. Uh, Later on, we have Nathaniel Gould in 1980. He add the modification to reinforce the extensor retinacular inferiorly and also to address the calcaneofibular ligament. I got the privilege to be trained by his son, Dr. John Gould, in SMI. So inferior extensor retinacular calcaneofibular, that was the emphasized in the Dr. Gould modification. And later on, when the arthroscopy became one of the tools, um, we recognize that those patients with these ligament injuries, they have intra-articular pathology. There was a famous shoulder surgeon when they start doing arthroscopy about the shoulder, considering that the arthroscopy is the tool of the evil. And later on, we realized that become a gold standard in the treatment of the rotator cuff. So part of the technology and the advancement of this, it would recognize the importance of arthroscopy. One of the criticisms from the person who is not familiar with this, they recognize we do the arthroscopy for dollars, and really what we need to know is we do the arthroscopy for outcome. And I'm very pleased to see that in general the consensus is arthroscopy plays a very important role in all the orthopedics pathologies and treatment. Having this one in mind, I recommend it, and I want to emphasize the concepts and also one of the particular techniques I discussed later. The concept that I want to share with you is the lateral complex. So remember, it's not only the rupture of one ligament, it's the lateral complex structure with two posts, the ATF, CF, and in the middle, you got the capsule, you got the extensor retinacular, and you have a big structure coming close to the peroneus tendon. That's the tendon sheath. It's very strong, very good structure to help us to repair this damage. So the concept is the lateral complex injury instead of called the ligament injury, and the three ledges repair, and we do it through the smile incision. So here in detail, we can see how the incision is made probably about 1 centimeter below to the tip of the fibula. What we try to get is the soft spot. The idea with this is try to repair with imbrication the tissue. And although there are some people feel more comfortable doing with the anchors, I feel more comfortable doing it the traditional way to the soft tissue. And going in detail, you can see how here is the peroneus tendon. We got the retractor to protect it, and underneath, that's where you found the CF, calcaneofibular ligament. Here, the extensor retinacular is retracted inferiorly, and here posteriorly is being protected, the sural nerve. Anteriorly, if we go close to the portals, we can identify the ATF ligament. Now in more diagram, you can see here when we've been released the peroneus tendons for this dissection is being cut, the calcaneofibular ligament, and continue the extensor retinaculars, and more anteriorly, we can see the ATF. The MRI is very visual. We can see the horizontal positions or oblique positions of the ATF, and now this long ligament between the fibula passing the talus, passing the calcaneus, is the calcaneofibular ligament. This paper was presented in the international meeting in the third anniversary of the Department of the Orthopedic and Traumatology in Universidad del Valle in Cali, Colombia. I have the honor to be one of the international guest speakers with Dr. Augusto Sarmiento, very well known, and actually was a past president of the American Academic Orthopedic Surgeon. In the next step, the next chapter, we will discuss details in the setup of this technique. Thank you.